Welcome. My name is Keith Naunheim. I'm the Secretary of the SCS. I'm here with Peter Smith, who's the Chief of Cardiothoracic Surgery at Duke and has been in charge of the SCS's billing and coding efforts for nearly a decade. Alan Speir, who is on our Government Healthcare Committee. He's a private practice cardiac surgeon in Virginia. And many of you know Jeff Rich, former STS president, and also spent a year at CMS as a medical director, so has really inside knowledge of everything there is to do with healthcare and coding. We're here because the final rule from CMS this last year suggested that Medicare wants to and is planning to get rid of the global surgical package. That is the 90-day global that we've been living by for nearly the past 25 years. And it could have profound effects not just on us, but more importantly on our patients and on healthcare. I'd like to start off with Alan. Alan, could you just generally explain what is the 90-day global package?
Thank you, Keith. The 90-day global package, as we've understood it in our specialty of cardiothoracic surgery, includes the preoperative assessment of the surgeon and the patients and their families, the intraoperative care and the operative procedure, the perioperative care in the intensive care unit, the postoperative care in the step-down units, and the coordination of all of the individual providers as related to system failure and consultations, and then the coordination post-discharge for those patients that have ongoing medical issues and is related to their surgery that extends out to 90 days.
And currently that's reimbursed
This
in
is
one
reimbursed
lump sum?
in a lump sum that has been based on the CPT codes that is all-inclusive of those functions and jobs.
And so Medicare has said they want to get rid of that. And Jeff, you know Medicare better than any of us. Why is it they want to abolish the 90-day global?
I think there are several pathways for that decision. One, it's coming from above. It's not just CMS that wants to abolish it, but the problem is that they did a survey. They surveyed some specialties, and they found that those specialties were not providing the care that Alan described postoperatively. So they felt they were paying for care that was not being furnished by the surgeons. So they did a study, and Medical Payment Advisory Committee advised the Congressional Budget Office that there's $700 million in savings if they abolish the global period and pay us for our intraoperative work, and then pay us post-operatively by us billing every day that we go there along with the other providers.
So that's going to be a big change from just a single lump sum for a 90-day period of time?
We'll get paid for our intraoperative work component, then we'll get paid for what we would call E&M codes afterwards, and Peter will probably speak to that more. E&M codes afterwards for ICU care, for care coordination activities that you described, and care that we provide in the office in the post-operative period.
I know, Peter, you've been working with the RUC for years, and the RUC has been in contact with CMS about this. How do you think the payment's going to change? What sort of system are they going to go to? Can you tell us how the changes are going to occur?
Well, I wish I could, but no one really knows. I mean, I think I'd add to what's already been said that this is going to affect all the surgical codes, really, not just STS codes. This is about 4,000 codes we're talking about that would need to be changed into a model where we get paid for the day of surgery, basically, and we're able to bill independently for everything else. CMS has given a few indications about how they might do this, because obviously this would cause the current payment to be reduced drastically to make room for us billing the embedded E&M values that are already there. They'll be taken out, and then we'll bill independently. So the net impact is a little bit uncertain, and it depends a lot on how CMS changes the values of, it's actually 4,200 codes. Ours are all among them, almost all, and you know, we'll just have to really work hard to either slow this down or make it something that they do accurately. If it's accurate, we should prosper. If it's not, we and others are going to be in a great deal of difficulty.
Jeff, how do you think this might affect the really important question. That is, how is it going to affect patient care? How is it going to affect the health of our especially our elderly patients? Because 2/3 of our patients are in the Medicare population or over the age of 65.
Sure. Just to follow up on what Peter said, this is a monster regulation. It's going to have massive impacts if it's not done very well. How will it affect our patient care? Right now, we do a great job. We know we do a great job. We have within our database an increasing acuity score for our patients over a decade, yet mortality is falling. And some of that is due to our care coordination. We are soliciting the help from specialists outside of our specialty to help manage their infectious disease problems, their renal failure problems, their neurologic problems. And I would submit that that care coordination has led to a decrease in mortality over time, while our patients have become older and sicker. With the new regulation, we're going to go from a care coordination model to a care competition model. So afterwards, we're all going to be submitting E&M codes for critical care. We're going to be submitting E&M codes that help manage their renal failure, help manage their postoperative care, and so will the specialists. So I think that we will begin to compete with our specialist colleagues for E&M coding and E&M billing afterwards. CMS is not going to pay for duplicated care. And so we run the risk of every day being the first in line to submit a bill so that we get paid for that day's work. And secondly, I think it's going to be very confusing for patients. They're going to get a multitude of bills that they never received before, and they really won't know who's caring for them, because there'll be a general sense that a lot of doctors are taking care of them different than it is now, where they see doctors talking at the bedside, and it's going to be a more competitive environment. So I would submit we go from care coordination to care confusion and care competition, which is bad. It's not going to lead to better results. I think it has the downside of not only leading to poor financial results for the surgeons involved in their care, but for outcomes for patients.
Jeff, go ahead,
just,
please.
Weigh in on one aspect of that is that right now, as we all know, the surgeon is the captain of the ship. It is our responsibility and sort of unique authority to coordinate, as Jeff mentioned, all the care. We'll be in an attribution and accountability issue with such unbundling. Who will then be viewed as being accountable? If there's a perioperative issue in the intensive care unit, will that now be a surgeon complication or mortality? If there's a failure to assess a perioperative problem on the floor with tamponade or dysrhythmias or electrolyte imbalance, will that then be put to the surgeon as a complication related to surgery? This is a totally uncharted course and one that we have not really defined. In addition, with such unbundling, the patients will now be facing additional charges for the copays as they follow up with the different providers. This may actually be a barrier and obstacle for many of our retirees, with the average retiree income is about $23,500 and their premiums are $4,000 annually is the statistic. As they're being forced on this limited income to pay for more copays, they may then not elect to have the follow-up care, which will dramatically affect not only their health and well-being, but our ability through the registry of getting those patients' data back into the registry.
So you think there may be a negative effect on the STS database and our ability to continue our quality improvement efforts?
I would say absolutely.
Let me ask you, Peter, you are certainly in contact with other specialties, especially through your connections with the RUC, the AMA RUC, the Relative Update Committee, which, as you know, helps sets values for all the procedures and all the services we provide. How is the RUC reacting to this? What do other specialties think?
Well, it depends. It varies by specialty. I think the surgical specialties are very concerned about this for many of the same reasons that we've already articulated here. The so-called cognitive specialties are pushing this, and they believe two things. One, like Medicare, they believe that some specialties and some codes that the services aren't being provided, and they also believe that the services that are provided by surgeons are less than the kind of inpatient visits that they're performing, so that they are actually pushing for this. The RUC itself is opposed to this and has gone on record in public comment to oppose this. So the general trend is to potentially work with CMS to try to make this right. And that's going to be extremely difficult because for those of us on the RUC, we know the details about how this will be done, and it's not going to be simple. Basically, we're undoing 20 years worth of work on 4,000 codes, and Medicare is proposing to change all of that in 2 years. Very concerning, what might happen. I think I might add a couple things that came to mind as you were discussing this. I think from a patient's point of view, this is going to be the loss of an insurance product. They're just paying one payment now for a coronary bypass operation, for example, no matter how long they stay in the hospital. But if they have complications and are in the hospital longer, they're going to be seeing a bigger bill that they're not used to. So this bundled payment for the typical patient is going to be gone, and people who have longer stays, and that's mostly Medicare patients, are going to have much bigger bills, and they're not going to be used to it. From a surgeon's perspective, it's going to be a big change for us because to this point we haven't been required to document all of these E&M visits, even if we do perform them. And so we're going to need to learn how to work with the system to be able to do that, to recover the payment that will be taken out of the system as part of this conversion.
I guess the question is, Medicare hopes for somewhere around $700 million worth of savings. Jeff, do you think they can possibly realize that kind of savings? Is that gonna come out of this change?
It's an estimate, and the estimates are always inaccurate, and particularly the ones coming out of the Congressional Budget Office. They typically don't value savings in the healthcare system, and so this is unusual that they actually said this will reduce the impact by $700 million. But when you think about the overall budget, that's nothing. To go through what Peter has described, to make CMS do all of this work, to go to a zero-day global, when we're talking about Medicare spending $700 billion a year on healthcare, this is just budget dust. And to go through all that work and to have this much disharmony occur as a result of that is just hard to imagine that this is the right thing to do.
Well, it also seems as if certainly the surgeon's costs will go up in terms of billing and coding. I've looked a little bit at the open lobectomy code, and currently 32480 open lobectomy, we'd end up putting in a single bill. If we make separate bills for each and every one of the preoperative, intraoperative, and postoperative services we provide, we're going to be submitting 11 bills instead of one. So certainly our coding costs are going to go up, but isn't that going to be true for Medicare as well? Even though it's electronic, if you increase the number of bills by a factor of 11, that's really got to make a difference.
Oh, sure. I mean, the number of claims will go up enormously. So your Medicare administrative contractor, there'll be 8 billion claims instead of 2 billion claims a year that they have to deal with. Each independent contractor. So it is very important to understand that there's going to be enormous rippling effect throughout the healthcare system. All the things that Peter described, from the patient not realizing the number of bills they're going to receive, all the way to the Medicare administrative contractors having to pay those bills, us having to submit those bills. The net impact will exceed $700 million in savings. It'll create much more infrastructure costs. I mean, somebody pays the Medicare administrative contractors to pay those claims, and who does that? Medicare. So they're not going to pay us, the global, but they're going to pay the Medicare administrative contractor to pay those claims.
And probably even more important than that is the point that both of you made, is that it has a real potential to harm patient care. If it gets to the point where we are competing for who's going to provide that service, and instead of a complementary multidisciplinary care model that you've described, that care coordination model, if suddenly we're jostling, we got sharp elbows and everybody's trying to get to the patient first, and because the surgeon needs to cover his office and all his costs, he has to give the care and doesn't get in the appropriate specialists when they need it, when they're getting incipient renal failure, or they need a pulmonologist for respiratory failure or whatever, patients are going to be harmed. And for sure, if they have higher copays, some aren't going to show up in clinic and some are not going to show up, and what could be just a weeping wound is going to turn to a wound infection, or diabetes is going to get out of control. I think there's a huge potential for real patient harm from this.
Sure. And I mean, you could imagine that a model of an itinerant surgeon will develop here, where somebody will do an operation and walk away and let specialists care for the patient and hospitalists and not be involved in the postoperative care, because it's going to be very difficult. There's going to be a lot of knowledge transfer and training that our surgeons workforce will have to understand and do in order to get paid. I did this. I mean, the surgeons who are listening to this, if you're doing TAVR and you're doing LVADs, you're already at a 0-day global. So you know how difficult it is to get paid for your services. For TAVR, which is an aortic valve replacement, basically, I tried as best as I could to bill appropriately with E&M codes, and I still came 30% short of what I would get reimbursed if it was an open AVR. And that's with every strong effort that I can do. So my thought, and I know that Peter's done an analysis on coronary artery bypass grafting, that the net impact can be pretty disastrous on our specialty in terms of loss of income.
Well, so it can be bad for patients. We think it's going to be bad for doctors, surgical specialists in general, certainly STS, the cardiothoracic specialists. And I honestly think it's going to be bad for Medicare. I think it's going to give them a black eye, and I think they're at real risk for actually perhaps even getting increased costs as opposed to decreased costs. So I don't see a whole lot of upside to this, and I guess I'd ask you, because you're in charge of government relations, so no pressure, but what is STS doing to try to mitigate or minimize any negative effects from this change? Are we trying to change it? Are we going along with it? Are we trying to work with them? I guess I'd ask you both from a RUC perspective and from a government perspective. First, the government.
When this initially was brought to our attention in and around the end of March and April, our response as the society was to coordinate with additional surgical societies, because this only affects the surgical specialties, not our internal medicine colleagues. But we reached out to additional societies and the American College of Surgery to then get a consensus as to both understanding and how we would jointly respond. We then met as a society with you, Jeff, myself, Dr. Fullerton, and our lobbyist, Courtney Yao, with the CMS to bring to their sort of insight what our concerns, all of which have been articulated today, to raise with them how this affects those that are primarily hospital-based, which obviously we are. We then have testified in front of the Congressional Committee on Energy and Commerce with the Subcommittee on Health just this past week, again reiterating, as part of the repeal of the sustainable growth rate, what impact the zero global would have, as this then moves us back toward paying only for volumes of cases performed under a traditional fee-for-service type of approach, as opposed to looking at alternative payment methodologies and bundle payment or others that the STS is in the process of promoting, in order to, again, consolidate care around the patient and quality rather than just on the number of cases performed. Our strategic moves will be based on the congressional response to that testimony, and then approaching individual members of Congress and the Senate Finance Committee on champion this cause because of the adverse patient effects.
And from a RUC perspective, are they working with CMS?
Yeah, right. So I think we'll be meeting this weekend, actually, here in San Diego, and CMS is going to be present during an all-day discussion of this issue on Saturday. And I think the RUC is going to be pointing out the limitations of how this can be done, the obstacles, and a way forward to see how it could be done fairly. But in addition, making them recognize the bar that they have to jump over and whether they really believe that they can do this, really within 2 years. And I think there's some skepticism within CMS already as to whether they can accomplish this, without making, large errors and sometimes unrecoverable errors. So it's really a two-pronged approach, is, to work with the legislative action to try to stop or delay this, and the other is, if it's coming, is to make sure that it works well. I think the major a thing that's going to be important to our specialty as this moves forward, if this conversion occurs, is specifically the issue that Dr. Rich mentioned about multidisciplinary care for our patients. We know that that model works, that it's effective, and that we're not having duplicative services. I don't think anybody is going to really deny that the surgeon should see the patient every day and be compensated for it. And Medicare has indicated that they're looking for suggestions as to how to manage fraud and abuse of billing, but they haven't come out flat out and say that they're only going to bill or pay for one provider each day for each patient. And I think we have to, as a specialty, support this notion that this is a teamwork thing that is making our patients get better care, and that's a linchpin thing, because this is the way they could really ratchet down on payment. But it would be not paying for necessary services, which I believe they're obligated to do.
Unfortunately, and then necessary services will not be delivered, and patients will suffer as a result. Jeff, more than anybody, you've been an insider in Washington, in the Beltway for a full year. You know the inner workings of Medicare, and you know really also from a provider standpoint, a practitioner standpoint, what it's like to give care. I wonder if you'd like to just summarize what you think, A, what's going to be the effect of this, and B, how we ought to proceed from this point on.
I think the effects have already been articulated very well. I think I would add it is a two-pronged approach for us to try and stop this from happening, both at the legislative thing, but also, as Dr. Smith has pointed out, to work with CMS to do it. From an insider, if I was wearing my CMS hat, this is an enormous amount of work that has to be done. I had 450 advisors working for me. You're going to have to add 100 advisors. You're going to have to hire 100 people to get this done in 2 years. I don't know that they have the wherewithal to do that. I mean, they can't just stop doing everything else that they do. Everybody's fully committed, so they're going to have to hire a lot of people to get this done appropriately. I think the impacts on them is going to be a huge amount of work to get it done correctly. I think the impacts on patients is very important, as I said, and as others have said. The care coordination, I think, will suffer as a result of this. And although they have not said that they won't pay for duplicated services publicly, I can tell you that privately, that's the notion that's out there. That, if you're treating renal failure, then we're going to pay the renal failure doctor if that's the primary diagnosis of the day. So you have to submit, not only an E&M code, but you're going to have to submit a diagnosis. So I don't think they'll pay for the same diagnoses on the same patient on a daily basis. So I think the impacts will be enormous. The amount of training that we're going to have to do for surgeons is going to be enormous. I'm afraid that we'll never get to the point where we're as effective as a cardiologist in building E&M codes like they do now, or for the cognitive specialists who are basically have that embedded in the way they provide care. So I think it's big. I think it's probably a direction that CMS does not want to go in, but they are being forced to take this in consideration.
So there you have it. This is a seismic change for not just cardiothoracic surgery, but for all surgical specialties as well. The proposed rule, then the final rule, was actually the opening salvo in what's going to be a campaign over the next 2 years before the 90-day global is finally going to be abolished. There's going to be ongoing conversations between us, between AARP, the RUC, AMA is going to be in on it, Medicare is going to be in on it. There are going to be a lot of changes, but this has every bit as much potential to be every bit as ground changing, essentially as sea change, just like RVS was back in 1989, 25 years ago. So this could effectively change the way we practice, and it is something everybody has to pay attention to. If indeed it does come to pass, we're going to have whole new changes, paradigm changes in the way we practice, the way we build, the way we interact with other care facilities. And ironically, to me, it's just one of those amazing things that for the past 5 years, I've heard Medicare say, you guys have got to bundle. We're going to global. And then the only global bundle that has worked for the last 25 years, they're suddenly going to do away with. Just doesn't seem to hold water. Anyway, I'd like to thank Dr. Rich, Dr. Speir, Doctor, your name is, Smith, that's the hard one. Dr. Smith, and I'd like to thank you guys for your attention. You're going to be hearing far more about this, and I warn you, it's going to be important for you to pay attention because this is going to be a big change. Thanks.